The Productive Dentist Academy Podcast Network.
When I get that patient say it's not bothering me, I say, I get that. And the problem is, I wish, this is going to sound bad, but I always tell the patients, I wish dental problems hurt. Because by the time it hurts, it's something else or it's too late.
Welcome to a special edition of Everyday Practices Dental Podcast and Investment Grade Practice Podcast. Today, we're starting with one of the most sensitive topics in dentistry: why patients doubt the diagnosis. In this two-part series, we interview Dr. Wade Kifer, a practicing dentist out of Fayetteville, Arkansas. As a Coyce Center course facilitator and Productive Dentist Academy faculty member with the Clinical Calibration Institute, Dr. Kifer produces 3,000 an hour. And yes, he is a clinical master, but he's an even better communicator and leader. In part one, Dr. Kifer walks us through how trust is built before the doctor ever enters the room, why your hygiene and doctor handoffs matter so much, and how to talk about risk, cracks, perio, and complex treatment without shame, pressure, or confusion. Let's jump in. Welcome to another episode of Everyday Practices Dental Podcast. Sara and I are here with two special guests. We have invited Victoria Peterson, CEO and co-founder of Productive Dentist Academy and host of the award-winning Investment Grade Practice podcast, to be here with us, in addition to recurring guest and phenomenally productive dentist, Dr. Wade Kifer out of Fayetteville, Arkansas. Hi, Wade.
Hey, Regan, happy to be here. Looking forward to it.
Thank you. This is going to be special, listeners, because it touches on a topic that really goes through marketing and building business value, and it's really what happens. The reasons why patients doubt the diagnosis, and it's a sensitive topic and a really, really powerful one. So that's why we've invited Victoria to be part of this as well. Not only because of your long history, Victoria, in dentistry, but also your history with Wade in particular, and how you have both seen and experienced each other's journeys grow over the decades.
I like the way you say that. We have history.
You go back a bit.
Well, you know what? He's been part of our Clinical Calibration Institute for a long time and just such a great PDA alumni. I don't think the world would revolve if Wade wasn't in it, honestly.
Very true.
Yeah.
It was 2010, I think I started coming to my first PDA conference. So, we're going on 16 years.
Yeah. Happy sweet 16, Wade.
Oh.
I could put you right in there with my anniversary year as well. How about that?
Oh, there you go.
Yeah, now I'll remember it. So go ahead, Regan.
Well, I was going to say, Victoria, in seeing diagnosis from your own chairside experience and the years that you had, with hygiene and how it's evolved over time, I'm curious, what you're most interested in hearing from Wade. Like if you think about, our listeners right now who are looking for those little nuggets, where do you start off? Doctor, if PPOs have you feeling restricted as a dentist, but you're not sure if going completely out of network is the right move for you, that tells me that you are right at the stage where having a strategy and plan is essential if you want to protect your revenue and grow. Investment Grade Practice, powered by Productive Dentist Academy, is hosting a live event this September that will help you design the right revenue mix for your practice. At Unrestricted, the End of PPO Dependency live, hands-on workshop, you get to work with renowned business and clinical experts who will help you analyze, clarify, design, align, and activate a plan so you don't have to feel restricted by PPOs ever again. Go to investmentgradepractice.com today for more information and to secure your seat. This event is strictly limited, so go to investmentgradepractice.com today.
Whew. I'm gonna punt right over to Wade because as a hygienist, what I know is that you take the cues from the doctors in the practice. Because we've been taught that even if you could drive a truck through a tooth, you can't legally say there's a hole in your tooth, right? And so, Wade, what I love about you is, and all the doctors that we work with, you are very conscious of what you can delegate and what you cannot. But you're also very conscious about empowering your team to educate that patient so that when you come in the room, you're in agreement. So, how important is it? Two-part question. How important is it that doctors and their hygienists and their treatment coordinators be on the same page? And then part two is how do you get on the same page?
Well, I mean, how important is almost like a loaded question because if you're not on the same page, I mean, that just decreases the value of the whole appointment to me, right? Um, and as far as like what they can diagnose and stuff, in our practice, as long as they're coming to it from a place of trying to help the patient out, there's ways you have to say that's caries to say, "Hey, I'm really worried about that tooth. We may end up needing to do a crown. If we don't do something on that tooth, you could lose the tooth. I'm gonna get Dr. Kifer to check it." But they've already created that value for the patient for when I come in, the patient's almost like, "Okay, what can we do?" Right? My job's easy. And that's very valuable as opposed to they don't say anything. If I find something that the hygienist didn't see and I look up and now I've got to start from scratch because the hygienist has said, because when I look in the mouth, I say, "Did you notice anything going on?" And so
Mm.
while I'm looking, she's telling me certain areas to look and double check. And not only does she say, "Yeah, I want you to check 2, 3," she'll say, "Yeah, found something on 3. We've talked about it." She gives me feedback right then and there of what the patient's thinking.
Yeah.
"We found something on 3. She knows there's a crack in it. We've talked, it may need a crown." And I'll say, "Well, but we want to get your opinion." Versus she found something on I found a little crack on 3. The patient said it's not bothering her at all. That little cue tells me a lot because now I need to explain why that crack is important, even though it's not bothering you, versus, okay, she found something on 3. It's concerning to her. What are we going to do about it? It's very slight, but now my level, when the patient says, "Well," I say, "Yeah, we can fix that. We're just gonna need to go and put a crown on that, like Casey said,"
Yeah.
versus, "Do I have to go into deep explanation or not?" And how do we get there? It takes practice. It doesn't just happen without
Mm.
post-appointment meetings where we go, "Hey, you said this, I thought this, what were you thinking there?" They don't have to be deep, deep conversations, but just at the end of the day, you talk over 1 or 2 patients with each hygienist, and over time, you just get on the same page, and life's much easier that way.
Oh, Wade, something that you just said sparked what I think so many dentists and dental teams experience every day, which is those patients that you know you've diagnosed the correct treatment, but they say, well, that one's not bothering me. And now that doubt starts to creep in from the patient perspective. So tell us a little bit more about how do you help the patient understand, because I know risk factors for you is part of just an everyday conversation. But walk us through how you take that doubting patient into treatment acceptance but it's not hurting me, Dr. Kiefer.
Yeah, so let's just do that crack in a tooth, and I'm not just talking a craze line, but maybe you can get the explorer tip in there. And so when I get that patient say, "It's not bothering me," I say, "I get that." And the problem is, I wish this is gonna sound bad, but I always tell the patients, I wish dental problems hurt, because by the time it hurts, it's something else or it's too late, right? And so I just look at it and say, "I wish this would hurt you only so you'd take care of it when we can, and it's not an extraction and maybe an implant or a root canal." So in a case like yours, where I've got this, your risk of this tooth breaking. Now, listen, I have plenty of work. I don't need to find things. And so if you don't do anything, that's fine. I am not going to pressure you, but I wouldn't be doing my job if I didn't say this
Mm.
was at a higher risk of future problems. And on me or my wife, I'm putting a crown on that tooth 10 times out of 10.
You know what I love about that is that you preemptive the story and the doubt when it does break, if they didn't follow through with treatment on time, and now they don't come in blaming you. Why didn't you tell me this tooth was gonna break?
Oh, we get them apologizing to us sometimes when they come in with a broken tooth or the toothache,
That's pretty
right?
cool.
And so
Yeah.
it's like, "You told me, I knew it." I said, "That's okay. We'll deal with it now." Right? So,
Woulda, coulda, shoulda.
Wade, you're a
but
tremendous communicator, and I don't think that that can be overstated. It's just beautiful to hear you walk us through it, and I can always, transfer it over to my own personal experiences with healthcare and have been in the place of, "You told me, and I'm sorry," but that grace that you extend to them. A lot of dentists say that it's a non-judgmental environment, and I think you just demonstrated a true way that you really are non-judging, and you're there to truly help someone. I'm curious, what do you think patients are really asking themselves when they hear a diagnosis? Whether it's hurting or not hurting. What goes through their head? Or maybe you as your own patient yourself. What goes through your head when you hear a diagnosis that may be surprising?
well, I always assume when I'm talking to the patient that they're gonna be skeptical. And I wanna give them permission to be skeptical. So, it's like Bruce and Victoria always say, "Handle the objection before the objection," right? So, when I'm doing that, I say, and all these things, I say, "We take pictures when we work so that you can see that crack," because if I don't get that crack in time, you could end up with needing a root canal or losing the tooth. So we take pictures of all the work, and I know we do it to send the insurance, but we'll take pictures just so you can see what we do. Because I want you to have that assurance that everything is done the best that you can, and I'll stand behind our work. We'll do everything we can to keep you out of trouble. So I expect them to be skeptical, and I kind of handle that objection before the objection. And at the same time, I'm very confident in my treatment plan too. When I was a new baby dentist before I came to PDA, I mean, I would go on tooth number two. We're going to do this mesial surface and this distal. And I talk all surfaces and how many teeth. I don't even tell them how many cavities they have when I leave the room. I'm like, "You've got a handful of teeth we need to fix up."
A
I kinda showed you
handful.
that
That's now today, or
handful.
that was when you were a baby dentist?
Well, today I just say a handful.
Oh, you do? Okay, so
Oh,
you just
yeah,
you
because I
got a
used to say,
bunch, buddy.
"It's this many," and I'm like, There's a lot of damage," and I mean, we're gonna get it fixed, but the real key to this is just making sure we don't continue on with this damage. So, with the tools we have
Mm.
nowadays, you're gonna have 2 treatment plans. I'm gonna give you 1 treatment plan to fix the damage and another treatment plan to make sure we don't do this again. And Casey's gonna go over both of those with you. If we can't whatever reason, if you can't afford or don't have the time or scared to at least fix the damage, we at least need to implement the plan to make sure things aren't getting worse,
Mm.
Has
right?
technology helped you, Wade, in this? Because I know that you've said that dentistry is a natural connection between science and people. How has that changed over your career, and how are you bridging that today when it comes to diagnosis?
Well, I actually look forward a little bit to AI and the different technologies as it comes forward because, when we can run a spit test and tell that you have perio disease from enzymes and things, I think that'll take a lot of it because now as dentists, I think we have it harder than a lot of medical professionals because probing depths are kind of subjective. Inflammation's kind
Mhm.
of subjective. I mean, we
Mhm.
see it, but you go to the doctor and you get a blood pressure cuff, right? Your red blood count, and your white blood count, and your blood sugar, they are what they are.
Yeah.
The doctor's just reading labs, whereas we have to interpret what we see in the mouth. So I do think that makes
Mhm.
it harder. Bruce would always say he didn't need photos, but because he had a link with the patient and built trust.
Mhm.
Now, I still use photos and intraoral cameras and big DSLR camera photos and um, STL scans. I use all those things and they're tools. And the patients all the time brag on all these tools that we have. But at the same time, it really comes down to the trust side of it to me is more valuable. Now I think a lot of the, when we said baby dentists, I was just kind of joking, but younger dentists built those communication skills because you're giving me credit for communication, but
Mhm.
it's a skill too. And, I'm trying to get better at it every day. And so just because we do something well doesn't mean we can't do it better. That's probably my biggest fault. My team gets annoyed because we can always do it better. So as those technologies come along, I think they help us. But even if, I know Reagan, some of your stories, you go to the doctor, they can have all the technology in the world, but if they don't make you feel like they care, you can't replace technology with that.
Absolutely.
100%. I heard the word value pop up, and before we were recording, I said everything is marketing and everything is value, and Victoria went, no.
Not everything is value.
Or
Yeah,
oh, do you want us to jump in on that?
yeah, I do want you to jump in on
Yeah.
that.
Well, I heard value. I heard you say words like trust and confidence. And, this whole topic is about why do patients doubt the diagnosis? And it really does come down to the clinician's confidence. You've already walked us through how do I calibrate with my team when we see this is what we do, or these are the options. And you had a phrase, I attribute this to you. You may have swiped it from the Coys Center, and thank you for being on faculty there and giving back to this industry. It's just so important that next generations, and now you get to say next generation doctors keep coming up to shine the pathway forward. But was it you that said once you have the diagnosis, uh, the treatment plan writes itself. The most important piece is the diet. Is that Albert
No, no,
Einstein?
it's similar, but and I get from Dr. Coy says there's only one correct diagnosis, right?
There you
So,
go.
but there's a lot of different treatments we can do to treat that diagnosis.
Yes.
Right? And so, if you relate it to some kind of cancer, it's like, oh, you have this cancer and you do the oral path report, and it's like, well, we could choose immunotherapy, we can choose chemotherapy, we can choose radiation, and different doctors may have a different surgery. All those are treatments for that one diagnosis, but the diagnosis is only one thing,
Right.
right? And so I'm confident in my diagnosis, and when I'm not. Sometimes we just don't know the diagnosis and we want to be confident and I don't know. But then once we have that diagnosis, we can discuss. I set a crown for that cracked tooth. Could it be an onlace? Could someone argue an inlay? Could it be no treatment at all is a treatment option for that patient? And so when I give a treatment, I say, I used to give all five options. And now I say, well, this is what I would do in my mouth,
Right.
because that's my treatment option. And I don't try to phrase it that that's the only way. I'll say there are other things we can do, but this is the one I would do. And we don't try to confuse them with a bunch of different or treatment plans for that one diagnosis.
I love that so much, and that's a point that you and I and Jackson Bean and Michelle and others Dr. Cooch, who have laid down some of our clinical. Um, for those who don't know, the Clinical Calibration Institute is all about diagnosis. That's it. We're not in there teaching you how to prep a tooth or how to do any of that. It's like, what are your diagnostic tools? Is everybody reading that diagnostic tool the same way? What is perio stage 1, 2, 3, and what are the nuances? What is caries? How do you diagnose it? Because once you get the diagnosis right, you could go, sling back beers for the next 5 weeks and
Yeah.
still not have consensus on a treatment plan amongst 12 doctors. So I love that you give latitude for that, because that's autonomy.
Yeah.
And in that, you're giving patient what the American Dental Association in their code of ethics says is veracity. You are telling them the truth, the whole truth, and then you're giving them choice. And that's our job, is to diagnose and give patients enough into education to make an informed choice about their health. Is
Well, let
that
me tell you, yeah, let me tell you a quick story because I was just up at a working with some students, and we look at the perio measurements and the inflammation, and we have bleeding points, and we can look at the chart, and it is class 2 stage B perio, but a lot of the dentists there were like, well, I would just prophy that in my office.
I was gonna ask you that.
To them, well, it's only bleeding in 6, 7 spots. And so we have so much information now, and that's what's great about Michelle and the Clinical Calibration Institute. And I mean, you can get it in other places, but it's all packaged there. How do you diagnose these things? Because when we're missing that diagnosis, then we're not giving the patient the best options, because that affects their total health, right? It's related to dementia and heart disease and diabetes and all these things. And we know this without a doubt. So if you're not trained on the diagnosis, now, once you get that diagnosis, we can discuss arrestin versus scaling and root planing versus lasers versus perioportation, I mean, whatever. But if you
Versus
don't get the
minute
diagnosis
favorite.
right in the first place, then
Right.
yeah, you're
Why do
lost
we
from the
have
start.
that gap? I'm just gonna nerd out.
That
Let me for a second. Why do we
no,
have this gap between prophy and periodontal therapy? I mean, every doctor I have ever
yeah.
onboarded, the first question I ask clinically is, what's your philosophy of care when it comes to periodontal therapy? And the answer is always, it depends. And I'm like, "On what?" "Well, which
Yeah.
hygienist is working that day? And, we had a good one, but then she left, and then this one, likes just doing and I don't wanna lose them." And, like, why is there such a cat that seems to be the battleground? Why?
Yeah.
Do you have theories?
I don't know, because I get the occlusion one is harder to diagnose unless you have the background of training, but
Yep.
caries and perio should be the same diagnosis
Mhm.
on everyone. I mean, it is laid out. If you have this much bone loss and this much inflammation, you tie in these factors. I mean, the American Periodontal Association has it all laid out, and it
It's
is
even on
what
a
it is.
laminated sheet.
Oh, I knew. We have it on a laminated sheet, and we go over it with the whole team, right? Because every hygienist should diagnose it the same and tell
Yes.
me. And
And do
so,
you think that we're getting, to the point where salivary testing is critical, or that's still adjunct?
I use it salivary testing, but I will not say it's an always. And I'll give you an example. I had someone in today, um, 30 years since they've been to the dentist. There is tartar everywhere, 4 and 5 millimeter pockets. There's a little bit of bone loss, but I'm like, once I knock off the tartar, this patient's going to be golden. I mean, we got 35 years of buildup, and they've
Right.
still only got 2 millimeters of.
They're not high risk.
They're not high risk. Now, they need scaling and root planing. They are a periodontal patient, but once we clean them up, now I'm actually using the periodontal testing on all the patients we define find perio on that have been coming to their cleanings. Because now
Ah.
we don't
Mm.
have a cause. I don't have 35 years of neglect. I got someone who's doing everything and they're still
Ye
breaking down.
yes.
Right? So if I've got you doing everything you're doing everything I've told you to do and you're still breaking down, then I've got to do the pathogen testing and viral testing. And what is it? What's the cause? Because I want to treat the cause, because you're doing everything right already and we're having problems. That's not normal. But I'm not going to brush those problems under the rug because you've been coming in every 6 months either,
Right.
because that's not
Do
the
you think that
diagnosis.
do you think that explaining these diagnostic tools and these risk factors give patients confidence and remove some of that doubt?
Personally, for me, I do. I think it fits into my communication style of why we have the problems we have. Because I'm really big on putting the blame on the disease, not on the person. Right.
What does that sound like?
Mm.
Well, in my practice, for example, I'll use an analogy. I'll say, do you know cavities is the most common transmissible disease in the world? We also know that periodontal disease is a transmissible disease too. They're both bacterial infections. Sometimes they have some viral or fungal components. And if it was all about you, meaning if you did a good job taking care of your teeth, you'd have nothing. If you did a bad job taking care of your teeth, you'd have periodontal disease and cavities. And you can't imagine how many of my patients have one and not the other. So what I tell
Mhm.
you is it's not about you. So just like eating right and exercising gives you a better chance of health, it does not guarantee health. I mean, I had a heart attack when I was 37 and I weighed 160 pounds, right? And
Yeah.
so when we do all that, you have to take in your body's response. And for
Mm.
you, and when I'm talking to a patient, you're doing a great job. I had this conversation today. 35 years, you don't have a single cavity in your mouth, but you've got gum disease. And is
Right.
that fair? Depends on how you look at it, you know? I mean, everyone's different. So we're going to take what you have and come up with a plan for you. So when a patient asks me, how often do I need to come back? I say, often enough to keep the disease away.
Oh, wait, I love what you're saying because my dad, for example, he would say to me, "Oh, Sarah, I hate going to the dentist because no matter what I do, I feel like it's so negative and they're telling me like I feel like they're telling me that I don't brush my teeth and I don't take care of my teeth because he still has his wisdom teeth. So those periodontal pockets are, harder for him to take care of. And what I love what you said is you're taking that emotion and kind of that judgment space that we talked about earlier, and you're removing that and just saying, "Hey, this isn't" I love when you said, "This isn't about you." Like, because we all take everything personally, right? But explaining that to the patient, I mean, talk about building trust, but also talk about now they're like, "Oh, there's a solution for me, and this isn't like every time I come in for my 6-month exam, I'm getting the shame, from Dr. Kifer." So I love that you talk about that. The other piece that I want to bring up is for those listeners who are just listening, Wade is in his consult room and has these huge, beautiful before and after mouth reconstructive cases flashing behind him.
Yes, go to
Big,
YouTube, listeners. It's
yeah,
gonna be
go to
on YouTube. You'll be able to
YouTube.
see it. Wade does
But
the most beautiful smiles on the freaking
oh,
planet. Better
yes.
than celebrity doctors that I've seen. So yeah, look up
Mhm.
Wade Kifer.
Yeah,
He's
Wade.
such a celebrity
But
doctor that people don't know he's a celebrity doctor. How about that?
I
That's
am
true.
not
He
on
is
social
actually, yeah,
media.
that's true.
we gotta
All the
fix that, Wade. We gotta
no, all
fix
the
that.
red carpets headed to Fayetteville. That's
Yeah.
where
I'm
they're
pulling
going.
us off
Yeah.
topic. I'm pulling us off topic.
Well, to bring us back where I was going was so this leads into kind of that other periodontal plus just those big overwhelming
Mm,
treatment plans that you talk about with the patient. So yes, you do a great job of explaining the diagnosis and what is the risk factor, but the reality is that a lot of our patients get overwhelmed with either the amount of treatment that's needed, the cost, the time that could be an investment on their end. So how do you make that clear for them, and how do you get them to say yes to something that can be very overwhelming?
Um, the biggest thing I think I do to say yes is because not everyone's gonna say yes, but that doesn't mean they don't deserve the opportunity, at least.
Mm.
Um, so, what I want to do is say how we got here. And I mean, it sounds bad because I've said this before, but if I can get down to the patient of what they're bothered by, what they want, and I say if I can get emotionally connected enough to get them to cry, to open up about whatever they have going on, then I
Ah,
know I've got them, right? And
mhm.
sometimes they just can't afford the treatment, but it doesn't mean they won't afford the treatment forever. It just means
Right.
not right now. And so when we give plans, some of these plans are 30, 40, 50, 60 plus $1,000 right then. We're doing one now that he's going to do a huge case, but he only has 10,000 to start. So we're doing some minor restorations and some Invisalign. And I mean, sometimes it just sucks, and this is life. If you've got $1,000 budget and your teeth are worn down, you just can't fix everybody. And I mean, it almost pulls at
Yeah.
your heartstrings a little bit, but at that point, it's just preventative care and trying to help things not get worse and hope things can get to a better situation. But um, I don't know. It's getting to know them and then find out what their click is, because a lot of people will move mountains to get the work done if they trust you and they know you've got their best interest at heart. And then there's other times that no matter what you do, it's just not going to work. My favorites are some of the patients that can't get the work done, but still refer us patients because they trusted us. It's just not the
Wow.
time for them right then.